This is a case of laparoscopy in a patient suffering from type 2 diabetes mellitus with hypertension. Patient having previous history of emergency OT cancellation due to the high sugar and blood pressure. Now after stabilization, patient planned for 3-port laparoscopic cholecystectomy. Through the epigastric port, you can observe both the transverse colon, ascending and descending colon, and the liver, the falciform ligament, and the distended gallbladder. Now we are going to introduce the 10 mm mid-epigastric port that has been introduced, and pneumoperitoneum, the pressure remains 10 mm of Hg and the flow rate remains 9. And now we are going to introduce the 5 mm mid-clavicular port, and the patient's operation here is done under the general anesthesia because of her uncontrolled BP pressure, and though the sugar is now controlled under medication, but the pressure remains still not properly controllable. So the 5 mm mid clavicular port has been introduced and you can see the distended gallbladder. The wall of the gallbladder is quite similar with the wall of the gut. The color is here quite similar with the lumen. So now we are going to introduce our monopolar hook. The first job is the additional lysis which is going on. So here the momentum has been adhered near the base, and the stomach and the part of the duodenum is well visualized. So small birds, and the diathermy voltage remains at 25 watts. So small birds is the main key for proper additional lysis. Now we are just separating the stomach from the gallbladder and the CBD. So our target is to visualize the cystic pedicle. So small birds is going on, and we are now separating both the anterior and the posterior calots simultaneously. And here the fat plane has been separated. The cystic lymph node, the lymph node of Lund will be visualized, and CBD can well be appreciated. Now our target is the cystic pedicle, and the triangle of safety here or Strasbourg to be well visualized. So small bursts, continuous changing of the traction and the counter traction here is main to make it more feasible. Now I am just separating it. The cystic artery and the cystic duct is going to be separated properly. The hook is an excellent instrument for doing such job, small and precise work, and also the bipolar shearer. But initially now here in this case I am using the hook for its more handedness, and it is the handy instrument. Now we are just trying to separate the cystic artery and the cystic duct. For this, the Maryland forceps has been introduced to make a room in between the cystic artery and the cystic duct. Small separation here is going on for proper visualization. and now the bipolar shearer is in, and I am just small tissue has been burst with it, and during application or coagulation, the entire metallic part has to be properly visualized so that there will be no transmission of current to any unnecessary bowel loop or any other port. So small burrs is the key for proper bloodless dissection here. So I am just separating it, and this fibrofatty tissue that are surrounding the lymph node of wound has to be carefully and precisely separated for proper applications of the Liga clip. So here you can see that the cystic artery and the cystic duct is well separated, and just below the cystic duct the CVD is going on. Now we are going to apply the clip. The 300 Liga clip has been introduced. So it is now being applied, and here you can well appreciate the color of the gallbladder wall and the lumen of the bowel. These are quite similar. Now again another 400 Liga clip has been applied, just distal to the previous clip. And now another 400 Liga clip has been applied, making a room or space in between the proximal 2 and distal 1 clip. Now again the endo scissor has been introduced, and it is now been separated. The cystic duct has been cut. Now we are going to introduce the cystic artery to be ligated. Now the cystic artery is being separated from this fibrofatty tissue, and for this the Maryland forceps is an excellent instrument for proper delineation of this structure, luminal structure within this fibrofatty tissue. The 300 Liga clip has been applied, and another 300 Liga clip will be applied along with the previous one, and we will separate the cystic artery with the help of the bipolar hemostatic forceps. So two 300 Liga clip has been applied here, and the bipolar shearer has to be introduced for proper separations and coagulation of the cystic artery. And during this bipolar shearer application, special precautions has been taken not to dissipate the heat towards the Liga clip. So for this purpose the traction and counter traction is going on. I am just properly trying to delineate the plane. Again the traction is changing, And now the gallbladder has to be separated out from the liver bed. As of it is an embryological plane, so it is usually bloodless, and this bloodless field has to be properly achieved and stick to this plane towards the gallbladder, not towards the liver. So small bursts is going on, and gallbladder has been separated out from the gallbladder fossa of the liver in a bloodless manner. Entirely, almost last 1/3 part of the gallbladder towards the fundic area is just remaining, and now it is being separated out, and the diathermy setting remains slow at 25 watts, so less fumes will be generated and less visibility problem will be encountered. So small burrs is the main key for proper separations and proper delineations of the plane. And now the last part of the gallbladder near the edge of the liver bed has been separated out. Now it is separated. Now we will introduce the endo bag. Here we are first searching out the bleeding present or not and proper hemostasis near the liver bed with the bipolar shearer, and gallbladder has to be extracted out through the umbilical port with the help of the endo bag. Here the gloves has been used for retrieval of the gallbladder as an endo bag. And after that we will thoroughly clean the peritoneum, intra-abdomen. Thorough peritoneal lavage will be done. So 10 mm port, mid-avigastric port, the telescope has been introduced, and the gloves has been introduced through the umbilical port. Now the gallbladder has to be poured within this endo bag. Now the gallbladder is in, and it is properly poured into the gloves endo bag so that none of the part will remain outside this endo bag. Entirely it is to be in. Now the gallbladder along with the endo bag has been extracted out with the abdominal, that is the umbilical port. The stones are getting stuck at the port site, so the track has to be dilated. I am trying to crush those stones within this endo bag, but due to their hardness it is not properly achieved. That's why I am going to dilate the track. So with the help of the large cardiovascular forceps, now gallbladder is getting also stuck here, and it takes time and proper patience for specimen retrieval. Sometimes due to the thick walled gallbladder along with the large stones, multiple large stones, that will create this kinds of problem. It is very much difficult to retrieve the gallbladder sometimes from the port side. In that case, I prefer to always crush those stones, but if not possible, in that case only I will taking out those stones after dilating the tract. So sucking the gallbladder along with its content, biliary content, with the help of the sucker. And now the stones are getting stuck here. So slowly maintaining the proper traction and counter traction, I am just trying to retrieve it out. So entire specimen is out, and the umbilical port has to be properly washed out with the betadine normal saline. And after that, you can see my left hand index finger to occlude the port, and proper washing of the port is needed. Now the port has been reintroduced for proper thorough peritoneal lavage, which is the main key for early patient mobilization as per the ERAS protocol. So thorough peritoneal lavage is going on. So again the 10 mm 30 telescope has to be introduced through the umbilical port, and with the help of the epigastric port, the suction irrigation cannula has to be introduced, and with the help of the 5 mm mid-clavicular port, I will going to introduce the bowel gasper for proper visualization of the calots triangle clip area and whether there is any bleeding from the liver bed present or not, and thorough irrigation with warm saline and the suctioning is carried out simultaneously, and entire field is bloodless, no bleeding from the liver bed or from the tip sides, or no leakage is there. And you can well appreciate that the cecum as in colon area, that has to be also sucked out. The and making the abdomen entirely dry enough so that the post-operative recovery will be smooth for this patient. So our main purpose and thorough peritoneal toileting is almost complete. Just going to see any fluids. The uterus, you can see the abnormal changes, the distended gut loop, engorged veins at the ovarian ligament can also be visualized.